As a country, we have set to eliminate malaria by the year 2030. And to be able to achieve this as a national malaria program, we've developed our 5-yearly strategic plans. So currently we are implementing the Kenya Malaria Strategic Plan that started in the year 2019 to go to the year 2023. And the vision of that strategic plan is a malaria-free Kenya, and we aim by the year 2023 to have reduced the malaria incidence and deaths by 75% of the 2016 levels. So far, the interventions that we've had for controlling malaria in this country are one, what we call the prevention interventions. We normally target that all the people living in malaria risk areas at least have appropriate malaria prevention interventions. In this country, we mostly have 3 of them. Number one is the use of insecticide-treated mosquito nets, which we do distribute through mass campaigns like we are doing this year, that is currently ongoing, where we plan to distribute, or we are distributing, close to 16 million nets to cover 25 million Kenyans and protect them against malaria. Also, in mothers and children living in the malaria transmission counties, we do give nets. When these mothers go to antenatal clinic, when they are pregnant, we give nets to protect them against getting malaria. As we said, pregnant mothers are at high risk, and also children less than 1 year. The second intervention we do is the indoor residual spraying. This is mostly in 2 counties, Migori and Homa Bay, the highest burden counties for malaria. It's also an effective intervention. And lastly, but also most importantly, is the prevention of malaria in pregnancy, whereby mothers, when they come to antenatal clinic, we give them sulfadoxine pyrimethamine, what we call Fancida, from about the end of the first trimester till delivery. We give them this monthly, and it's able to protect the mothers against malaria and the adverse events from it. We are planning to introduce larva source management, where we spray mosquito breeding sites with larvicides. The second way of controlling malaria in this country is ensuring that anyone who displays any symptoms for malaria is tested within 24 hours and put on appropriate treatment that we've mentioned. And the last intervention that we have is what we call social behavior change communication, whereby we target, or rather we educate the public, we sensitize the public that they need to take up the malaria prevention and treatment interventions available. It is one thing to distribute a net. It is another thing for that net to be used. It is one thing to recommend people, once they feel sick, they should go to a facility, get diagnosed and treated, while we still know a big population of people, when they fall sick, they walk into a pharmacy and request for treatment without diagnosis, which we quite encourage. Coming in of a vaccine may or will definitely accelerate the progress that we've made towards meeting our target of eliminating malaria by the year 2030. Malaria lake endemic counties, where the burden of malaria is highest, with 1 in every 5 people being infected with malaria at any given time. We also have the areas around the coast region, what we call the coast endemic region. In those 2 regions, malaria transmission occurs throughout the year, so it means you can get infected throughout the year. The light green section is the area we call the highland epidemic-prone regions, where malaria occurs during the rainy seasons, the 2 rainy seasons that we have in the country, the long rains from March, April, and the short rains from October. The very purplish area is what we call the seasonal transmission areas, where malaria occurs when especially there are heavy or prolonged rains unusual. It's only at the center of the country, the dark blue region, where we call the low-risk region, where not much of malaria transmission occurs because, one, of the climate, it's a bit cooler, and so the transmission doesn't occur there. A lot of progress, however, has been made in this country through the interventions implemented by the Ministry of Health in collaboration with partners, whereby we've seen the incidence of malaria reduced by 74% since the year 2000, and averted around 102 million malaria infections. The prevalence of malaria has also been gradually declining from a high of 11% in the year 2010 to 8% in the year 2015 and 5.6% in the year 2020, according to the malaria indicator survey that are done every 3 to 5 years. Again, through the interventions implemented by the Ministry of Health in collaboration with partners, we've also reduced deaths from malaria by 46% and averted 124,000 deaths from malaria since the year 2000 to date. This intervention has seen our map for malaria, what we call like a heat map, showing the intensity of malaria in the country, change from, dark red, red regions in the year 2000 to the current map that we have now, where we are saying, apart from the lake endemic counties, the counties around Lake Victoria, the counties around the Indian Ocean, and some other sub-counties within counties like Tiati sub-county in Baringo or Loima in Turkana around the large water bodies, largely the incidence of malaria has reduced in the country. But despite the progress that we have made, as we speak, malaria is the second leading cause of hospital outpatient visits in the country. It's only second to diseases of the respiratory system, whereby about 15% of people who will visit a hospital outpatient will be due to malaria. Malaria is still a leading cause of loss of pregnancy, loss of pregnancy early, miscarriages, stillbirths, low birth weights, premature deliveries. Malaria is a cause of that. It's still a leading cause of maternal mortality. When malaria infects somebody, it attacks the red blood cells, the cells that carry oxygen in our blood. And mothers, when they are delivering, naturally, there'll be some bleeding. So if they already have malaria infection that has reduced their level of blood, even a little bleeding can lead to death. So it's still a leading cause of maternal mortality. It is also a leading cause of under 5 deaths, sickness and deaths, being that children under 5 are also most vulnerable to developing severe malaria once they get an infection. We will take an example of last year. Within the public health system, we tested over 10 million people for malaria in 2020, and 4.1 were found to be positive. So you can already see that despite the progress that we've made, we still are seeing a lot of malaria infections. Luckily, we have good diagnostic kits, malaria diagnostic kits, or diagnosis through microscopy, and we have the recommended first-line treatment for malaria, which is the artemisinin combination therapy. In our country, we use artemether-lumefantrine.
We did participate in the clinical trials between 2009 and 2014, and Kenya was among the 7 countries, and we had 7 clinical sites, that is Siaya, Kilifi, and also Kombewa. Subsequently, we did express our interest in participating for the pilot implementation, and in 2016, we were selected alongside Ghana and Malawi to pilot the malaria vaccine. We did, before any vaccine is introduced in the country, it has to be approved by the National Regulatory Authority, and that is PPB, approved the use of the malaria vaccine in those endemic counties. And recently, last week, we did have the big news that WHO has actually recommended the wider use of malaria vaccine across sub-Saharan settings in areas with high to moderate transmission of the disease. We did integrate the malaria vaccine within the immunization program, so it leveraged on the existing systems. We do use a network of 600 health facilities across the implementing counties, and they are public, private, and we give the vaccine free of charge. It's leveraging on other interventions within those counties, so it's being given alongside the malaria control interventions that we do have in place. So malaria vaccine is not replacing the other interventions that have been laid down by the National Malaria Control Program. That is the malaria vaccine schedule. It is a 4-dose schedule. The first dose given at 6 months, which coincides with vitamin A administration. The second dose given at 7 months, where children come to the hospitals to be weighed on a monthly basis. Then the third dose is given at 9 months, which coincides with the first dose of measles rubella. And then the fourth dose is actually given at 2 years. So you see, all these doses are integrated within other childhood vaccination schedule. The introduction of malaria vaccine gave us an opportunity to strengthen the health system. Before any new vaccine is introduced, we do engage with the counties at various aspects. There was a planning, we did the planning with the counties, and then there were introduction, we did purchasing of additional cold chain equipment, where these vaccines were going to be stored. We strengthened other aspects of the immunization program. So for example, communication, community engagement. So it brought benefits to the health system in terms of implementation.
In 2019, malaria was responsible for the deaths of an estimated 409,000 people, mostly children under the age of 5 in sub-Saharan Africa. Due to the unprecedented investment in malaria control tools such as insecticide-treated bed nets, indoor residual spraying, and artemisinin-based combination therapy, approximately 1.5 billion cases of malaria and 7.6 million deaths have been averted. However, in recent years, our gains have somewhat stagnated. To make further progress in the fight against malaria, we need new and still better tools. Malaria researchers from CDC, in collaboration with our Kenyan partners, including the KEMRI, the Division of National Malaria Program, the National Vaccines and Immunization Program, and the 8 Western Kenya counties, Busia, Bungoma, Homa Bay, Kakamega, Kisumu, Migori, Siaya, and Vihiga. These have been instrumental in this significant milestone. CDC's 40 years collaboration, particularly on malaria research here in Kenya, including most recently with the RTSS pilot introduction here, contributed to the WHO recommendation and helped pave the way for wide-scale implementation of this promising new intervention. I applaud every individual who was involved in the RTSS rollout here in Kenya. Each of you played a critical role in advancing global public health. In the words of Nelson Mandela, it always seems impossible until it is done. Wakati ni sasa hivi, hongera, asante sana.
The World Health Organization congratulates the government of Kenya and its people for the unwavering support and participation in the pilot implementation. We acknowledge the strong leadership of the Minister of Health and the government of Kenya, the counties where these pilots were implemented, and I also want to applaud the communities and families who participated. I sit on scientific advisory committees that discuss building capacity for clinical trials in Africa. And every time we are seated in these meetings, the question is, what's the investment of African governments? We've always argued that even space is investment. Our people is investment. It's not only money. So I really want to acknowledge and appreciate the communities and families who participated. The World Health Organization has recommended the widespread use of the RTSS malaria vaccine among children in sub-Saharan Africa and in other regions with moderate to high Plasmodium falciparum malaria transmission. And the recommendation is based on results from the ongoing pilots, as we've already had, and which has reached more than 800 children since 2019, and through routine immunization programs under the leadership of the Minister of Health in all the countries where the studies have been ongoing. We note that there's been no negative impact on uptake of other malaria interventions and even other routine immunization services, and this is important. as the malaria program manager spoke this morning, that we want to move towards eradication. So we need new tools. The vaccine is cost effective. We've noted the significant reduction in severe cases and the reduction in deaths. The recommendation for broader use means that more communities and children have an opportunity to be reached, and more lives will be saved and improved. The Gov't board will discuss future financing of the malaria vaccine later this year. Again, the Malaria Control Program Manager made reference to that, but we have a timeline, and we wait to hear from the decisions of the board on this.
The recommendation by the WHO for the broader use of the malaria vaccine signifies a new dawn in ending malaria in the country, the continent, and beyond. We recognize that this is a momentous occasion in the fight against malaria and join our partners in welcoming the recommendations for widespread use of the malaria vaccine in sub-Saharan Africa. Malaria is one of the top 10 causes of illness and death in our country, as had been stated clearly by Dr. Githuka. In Kenya, the Ministry of Health made significant progress in the fight against malaria by enhancing use of insecticide-treated mosquito nets, larviciding, indoor residual spraying, and appropriate diagnosis and treatment using artemisinin-based combination therapies, and of course, social behavior change communication. It is largely as a result of these efforts that the proportion of people affected by malaria declined from 8% to 5.6% nationally between 2015 and 2020. One such tool is the malaria vaccine, which is a product of over 30 years of research. The RTSS is the first and only malaria vaccine in routine use and is already available in some regions in Kenya. You know the 8 counties where the trial was conducted, but in specific sub-counties. 8 counties and 26 sub-counties in the malaria endemic area in the Lake region, that is Kisumu, Homa Bay, Migori, Siaya, Kakamega, Bungoma, Vihiga, and have been administering the vaccine as part of the routine childhood immunization. Since the vaccine pilot implementation program began, more than 200,000 of our children have received at least one dose through this effort. We acknowledge that parents, guardians, caregivers, and healthcare professionals have embraced malaria vaccination. We believe this has contributed to the increased demand and uptake of the vaccine. In the coming days, the Ministry of Health will consult with experts and advisory bodies to make considerations on the expanded use of the malaria vaccine in other parts of the country, taking note of the in-country morbidity data and other regulatory provisions. I urge all partners, stakeholders, and the media as a key partner and custodian of public information to work with the ministry and create awareness on availability of the vaccine that is aimed at eradicating malaria in Kenya and Africa. I thank you.